Good morning, everybody. Just to stay on time, we're going to get started with the 12 rounds today. I'm Khaled Ziada. I'm one of the interventional cardiologists for those who don't know me. The topic today is going to be diagnosis and management of ischemia with no obstructive coronary arteries or INOCA. We have a great set of talks to cover the topic in from all its aspects. Just to not to take too much time, we're going to get started. Our first speaker is Tommy Das, one of our rising stars in interventional cardiology, and he's going to give us a couple of case presentations.
So I'm just going to talk about a couple of cases to set the stage and get us started here. Our first case, this is a 71-year-old woman. She has a past medical history of the typical risk factors, diabetes, hypertension, sleep apnea. And she comes in as an outpatient, reporting a few months of dyspnea on exertion, some sensation of chest burning with moderate activity. These symptoms have been bothering her. And so she gets the following workup. She has a nuclear stress test that shows no evidence of ischemia. She has an echo, which is unremarkable, normal ejection fraction, no valvular disease. And given the nature of her symptoms and the persistence of her symptoms, she gets referred for a coronary angiogram, which you see the still frames of here. And importantly, really no evidence of any obstructive disease, some mild non-obstructive stuff in the LAD, but otherwise no obstructive culprit disease that could explain her symptoms, right? Contrast her case with case 2. This is a 37-year-old woman, has a past medical history of hypertension, tobacco use, and obesity. And she comes in more acutely. She has early onset, early morning chest pressure that wakes her from sleep, and she presents to her local emergency room. She has a EKG that's done in the ER that shows a left bundle branch, which is unclear the timing on that, if that's a new thing, and the emergency room is concerned this is her STEMI equivalent. They activate the lab, but in conversation with the team, her chest pain gets better, her hemodynamics are stable, her left bundle actually appears to be rate dependent more than anything, and she's got negative enzymes, so she gets re-triaged to the floor. And again, gets a pretty expansive workup. An echocardiogram that shows a normal ejection fraction, no valvular disease. Gets a coronary CT that shows some atherosclerosis, but no obstructive lesions. Even gets a PET scan with some concern for sarcoidosis, which shows no evidence therein. Has an exercise test that shows that left bundle is rate dependent and comes on with activity. And actually that test ends up being terminated due to fatigue and chest pain. So again, she goes for an angiogram, which again shows no evidence of obstructive disease. So while both these cases would probably have been conceptualized in the past as having non-cardiac chest pain, they didn't find any culprit on the angiogram. What we know now is that these patients have ischemia with no obstructive coronary artery disease, or INOCA. In 2018, the Covadis group from Europe actually put together these following diagnostic criteria for INOCA, essentially showing that patients would have symptoms suggestive of ischemia, an absence of obstructive lesions, ideally shown on angiogram, evidence of ischemia with functional testing, and we're going to talk about some of the ways that functional testing can happen, and then evidence of microvascular dysfunction that can be looked at invasively or non-invasively, and we're going to talk more about the different types of microvascular dysfunction here as we go on. So, two main endotypes of INOCA that we're going to focus on today. One is microvascular angina, essentially wherein there is disease of the small vessels of the coronary tree, those that are smaller than the naked eye. And while those vessels may be small, they actually control most of the perfusion of the myocardium. We'll talk more about how that testing is done, but essentially, invasively or non-invasively, what we're looking for is a coronary flow reserve that's low and an index of microvascular resistance that is high, and we'll talk more about MLR later too, but essentially that can be tested for invasively or non-invasively too. We also have vasospastic angina as another endotype of microvascular, of INOCA. There is no standardized non-invasive ways to test for, but invasively, what we do actually is we can give a provocative agent such as intracoronary acetylcholine or intravenous ergonovine and look for evidence of spasm. We have both epicardial or macrovascular spasm, wherein we actually see the lumen of the artery shrink by about over 90%. And we also have evidence of ischemia by EKG and reproduction of the symptoms. And you have microvascular spasm, where you don't have that angiographic change in the vessel diameter, but you do have symptoms and you do have EKG changes. So with that groundwork, we're going to go back to our two cases. Case one, this is a woman in her 70s who had typical symptoms but a negative angiogram. She goes to the lab, she has her negative angiogram, and then she goes for microvascular testing. And we'll talk more about this screen later, but essentially you'll see that her CFR is low, her coronary flow reserve is low, and her index of microvascular resistance is high. And so she ends up being diagnosed with coronary microvascular disease or microvascular angina as the cause of her symptoms. Our second case, this is a younger woman who had acute onset chest pain in the morning. Her CFR is high, or normal, excuse me, and her IMR is also normal. So she doesn't have microvascular disease per se, but when we do provocative testing with acetylcholine, on the left you see her angiogram at rest, and then on the right you see her angiogram after intracoronary acetylcholine, and you see that the lumen has spasmed essentially, greater than 90%. And additionally, she has reproduction of her anginal symptoms and EKG changes. So she gets diagnosed with vasospastic angina. So again, just two cases to set the stage and kind of show the different endotypes that we're talking about as well.
Good morning, and thank you for coming. So the picture on the left is the way we in the cath lab looked at coronary arteries for years. But the picture on the right is a little more representative of actually coronary vessels and perfusion, but we didn't look at that. Instead, we had many patients, typically women, who would come to us with chest discomfort. We saw nothing on the angiograms. We say, oh, honey, I'm sorry. Maybe it's in your head. Go see your psychiatrist. And unfortunately, that happened way too often. From an academic standpoint, the issue began to come to light with the NHLBI-funded WISE trial. Look at the date here. This was published over 20 years ago, but it's a really important study. So they measured coronary flow reserve using Doppler, which was the only available technique at the time, on 159 patients with chest pain and no obstructive coronary disease, and 47% of these patients had subnormal coronary flow reserve suggestive of microvascular dysfunction. Perhaps this overestimates the prevalence, but it gave us an idea that we were missing what I showed to you on the previous slide on the right side. What's the prevalence? This is really hard to know because you got to make the diagnosis, but to do that, you have to triage the patient to cath and then do appropriate in-lab testing. And still, in most centers in this country, we don't do that. So it may be as high as 40 to 50% of patients with chest pain, probably not quite that high, but it could be that high. And where does that data come from? Well, this is a report of over 3 million patients in the ACC NCDR registry undergoing catheterization. In column 1, which is right here, these are patients that had no stenoses greater than 20%. In column 2 are patients that had stenoses 20 to 50%. Now, granted, there's no FFR from this data, so it's rough. But look at this. It could be as many as 60% of the patients that come to the cath lab have some other form of coronary artery disease. More recently, the Ischemia trial looked at this. Ischemia and attempted to enroll over 8,500 patients. Those patients that had moderate or severe ischemia, they underwent CTA, and 13% of them were diagnosed with INOCA, most commonly women, younger women, and patients with less severe ischemia. One of the problems with this topic is this is a heterogeneous group of patients. Sometimes it's secondary to a variety of things, CKD, morbid obesity, HFpEF, and it's been very hard to sort out treatments that are effective. The basic cath lab testing has already been briefly described by Tommy. We have 3 basic measures. We can measure FFR and the epicardial coronaries by placing a wire down the coronaries and then measuring the pressure after the administration of adenosine. That's the standard test. But this ignores the prearterioles, the arterioles, and the capillaries, the latter 3 being evaluated by IMR, and then CFR is somewhat more all-encompassing. It addresses the coronary vessels in all of these areas. There is emerging data looking at the predictive capability of CFR and IMR in particular. And so if you look over here to get started, patients with an abnormal CFR are below this line here, and those with an abnormal IMR are to the right of this line here. So the double negatives or double positives are here, and they have the worst prognosis. The next worst prognosis appears to be in this group, which has an abnormal CFR but a normal IMR. What about treatment? Oh, this is woefully understudied. There are many usually non-randomized studies and no consistent benefit. This is from a relatively recent study. And the breakdown is as follows. I'll invite you to look predominantly at the non-hatched lines here. So these are placebo-controlled trials here. So we have all of 3 placebo-controlled trials looking at ACEs and ARBs. 1 showed effect, two did not show effect. Statins, 3 trials, no effect more commonly, and we go across the board. There's no real consensus or solid basis for treatment of many of these patients, maybe with the exception of bridges or spasm. But in terms of microvascular disease, we just don't have much data that's good. There are better studies to come. I'll just mention one, and then I'll step down. We are finally going to get some decent-sized studies in the near future. This is an overview of the Warrior trial, which will randomize 4,400 patients to atorvastatin, RAS blockade, or aspirin, essentially as a placebo. So there's going to be much more information coming down the line. I think in the next decade, we'll learn how to treat many of the subtypes of patients within this group. But I'll remind you, it's a heterogeneous group, and it's been a challenge to study over the years. Thank you.
So I'll be talking about predominantly PET and some CMR in the diagnosis of INOCA. So most of this will be about PET, and I want to answer these 5 questions. What can we diagnose with PET? What can we not diagnose with PET? How is it assessed? What are the different subtypes of microvascular dysfunction? And then what's the prognosis for people that have abnormal microvascular function by PET? I'll briefly talk about CMR for INOCA and then CMR for MNOCA, which is myocardial infarction with no obstructive coronary artery disease. So I think of INOCA in these 4 broad categories: microvascular disease, microvascular spasm, epicardial spasm, and mass diffuse disease. And as Dr. Young will talk about after me, these all can be assessed invasively, but the great limitation of non-invasive testing is it can really only comment on microvascular disease, and specifically CFR or coronary flow reserve. Now here's a typical PET scanner. So for those that may not be familiar, we have a rubidium generator here. You can see the bag of saline to give you a reference on how big it is. That sits just at the head of this PET scanner. And we inject the isotope with saline into the patient. Here's a typical protocol. So it's a very short-acting isotope, about 70 seconds. So you can inject the rubidium. We take rest images for about 7 minutes. Then we give regadenoson, that's our vasodilator, our stress agent, and we give another dose of rubidium, and we get our stress images. Now, many of you may be familiar with perfusion imaging. This looks very similar to SPECT imaging. But what PET gives us the advantage of is quantification of myocardial blood flow. I'm going to slow this down to see these time activity curves. And so we're actually counting the photons as they go through the right ventricle, and then the LV cavity, and then finally into the myocardium. And we can directly quantify flow into the heart. And that generates these figures right here. On top, we see stress flow. You can see it by vascular distribution and then global value. We see rest flow, similarly with vascular distribution and global flow, and then reserve, which is the ratio. Now, one of the things that's challenging about INOCA and microvascular disease is you'll see things named 20 different ways. Reserve, the same thing as myocardial flow reserve, which is commonly used in the PET literature, same as coronary flow reserve. It's just the ratio of stress to rest flow. Now, we consider a normal stress flow to be about 1.7 to 2.3 milliliters per minute per gram, rest to be 0.7 to 1.2, and then a normal flow reserve being greater than 2. So conversely, having a flow reserve less than 2 in the absence of obstructive CAD is diagnostic of microvascular dysfunction. And the big caveat being the absence of obstructive CAD, because obstructive CAD can cause you to have a low CFR. It's been described 2 subtypes of microvascular disease. In the PET literature, you'll see classical and endogen. In the invasive literature, you'll see structural and functional. But classical and structural are similar, and that's defined by having an abnormally low stress flow with a normal rest flow, giving you a low ratio. And the endogen or functional type, you have a normal stress flow, but you have high resting flows, and that's why you get a low ratio. The example I showed before is a good example of classic or structural CMD. You see a stress flow of 1.0, which is very low, a rest flow of 0.7, which is normal, and then a reserve of 1.3, which is very low. You compare that to this patient on this side that has endogen or functional microvascular disease. They have a very normal stress flow, but very high resting flows, giving them a ratio of 1.8 that's low. So that would be an example of endogen or functional CMD. Now, what are the causes of each subtype? There are a lot more causes than just this. It's a very complicated topic, but classical CMD is thought to be more of the very traditional CAD risk factors: hypertension, hyperlipidemia, smoking, diabetes. The endogen subtype of CMD, there's a lot of reasons. Hypertension, it's metabolic syndromes, obesity, tachycardia, high heart rates from anxiety has been associated with this subtype of CMD, renal dysfunction, vasodilator medications. It's a much more heterogeneous population. Now, what's the prognostic significance by PET of these values? So here's a paper that looked at patients with both abnormal perfusion and normal perfusion, but I'm just going to focus on the patients with normal perfusion. And we can see from these curves that those with abnormal CFR less than 2 had a higher risk of major adverse cardiovascular events and higher risk of cardiovascular death. We see the annual event rates were about 6% in those with an abnormal CFR compared to around 1% with a normal CFR. But CFR has also been associated with all-cause mortality. So in this study, looking at those with no perfusion defects, we see having a flow reserve less than 2 has a much worse prognosis compared to those with kind of intermediate 2 to 2.5 and greater than 2.5. So that's PET imaging. I'll spend just a minute or two talking about stress MRI for INOCA. Here it can be assessed in 3 different ways. The first is visually. If you look at this plot here, this is a still image of first pass for perfusion gadolinium, and you see this dark rim of subendocardial tissue. And if that persists, that can be evidence of microvascular dysfunction. There's semi-quantitative assessment. Tommy had mentioned the Myocardial Perfusion Reserve Index. I find this to be very complicated. It's the ratio of the slopes of the blood pool versus the myocardium at rest and stress, and the very specific value they got was 1.47 as the cutoff between normal and abnormal microvascular disease. But what's newer is direct quantification of myocardial blood flow. And this is where you're going to generate that same CFR, the same flow reserve by CMR. This is more in the research phase. The studies have shown it correlates very well with invasive testing and PET testing, but it's not always commercially available. We have this software in our research scanners, but this technology is not currently available on our commercial scanners. So if you order a stress CMR, you won't get this data. Now, lastly, CMR for INOCA. So this is patients who have signs and symptoms of ischemia. They have positive biomarkers, and they have non-obstructive coronary artery disease. This is just a study that looked at, pooled 26 studies, CMR less than 10 days, to ultimately try to diagnose what the INOCA was for. And they confirmed an ischemic etiology in 22% of patients, whether that was plaque erosion that was missed on angiography or spasm or embolic disease. But the remaining patients were reclassified either as myocarditis or Takotsubo, or there was a significant subset of patients that had normal MRI. So just to recap, PET-CT is a well-validated non-invasive tool to diagnose CMD, but it cannot diagnose other forms of INOCA. A CFR less than 2 in the absence of obstructive CAD is diagnostic for microvascular disease and comes with a poor prognosis. CMD can be split into 2 categories: classical or structural, which is low stress flow and normal rest flow, versus endogen or functional, which is normal stress flow with high rest flow. And then CMR is an emerging modality for INOCA, but is already a well-established diagnostic tool for INOCA. Thank you.
Okay, good morning, everyone. So we're going to kind of go through what we do at Cleveland Clinic Cath Lab once the patient's been referred for microvascular testing. We try and use a stepwise approach so that we're doing the same thing for every patient, having reproducible results and not missing anything. The first step seems obvious, but we need to rule out epicardial disease. Oftentimes, these patients are coming for either a 3rd or 4th opinion. They're being referred specifically for microvascular testing. They've had 1 or 2 angiograms back home with no epicardial disease, and so that's been done for us. But I think it's important to note that, sometimes an angiogram is the gold standard, but in intermediate lesions, we really do need to make sure that we're not missing something with physiological assessment or intracoronary imaging. As an example, I think we get this probably once every 2 or 3 months where a patient's specifically been referred to us for microvascular testing. This is their baseline angio as an example from a couple months ago. This is a patient that Dr. Ziada saw. You can see their LAD here with mild, moderate disease at most. He puts the pressure wire down with the intent of doing his microvascular testing, but finds that they have an RFR, which is the Abbott equivalent of IFR, of 0.72. So markedly abnormal. That should be above 0.9. So he does a pullback here, and you can see there's 2 different step-up lesions, suggesting maybe 2 discrete focal lesions that were missing on the angiogram. So instead of just ignoring this, proceeding with his microvascular testing, he appropriately looks for any disease on intracoronary imaging. And you can see, instead of, as we had expected on the angio, he doesn't find that everything looks kind of like this left-hand side where there's minimal disease. There's actually a bifurcation lesion here, probably hidden on the angiogram by that diagonal branch coming off. And then up top, in retrospect, you might see this haziness at this white arrow there where that septal comes off, and that's that calcific lesion that we're seeing here at 11 o'clock. So this patient actually had obstructive epicardial disease. They got 2 stents and actually felt much better, obviating any need for microvascular testing. So simple in and out for us, but important again to remember that in intermediate lesions especially, or if you're not sure and the clinical picture really suggests that there's epicardial disease, ancillary testing in the lab can be helpful. If we truly don't see any epicardial disease, then we're going on to try and differentiate, as Tommy had alluded to different endotypes. So microvascular angina versus vasospastic angina. And as we know, so there's no standardized non-invasive study for spasm, as Dr. Abadi had mentioned. So that's the real benefit of bringing it to the cath lab, is we can get comprehensive testing and give them kind of a definitive answer, you have this or you don't have any sort of cardiac angina. We do provocation testing in the lab, so we're using intracoronary acetylcholine the majority of the time here, but intravenous ergonovine can be used as well. Testing is typically done in the LED most places. We usually will do it in both the LED and the RCA to try and increase our sensitivity. And the criteria for diagnosis, I know Dr. Das had already gone over, but the biggest thing is that we want to see all 3 if we're looking for epicardial spasm. So they should have the reproduction of their ischemic symptoms. We should see ECG changes. They're all hooked up to a 12 lead for this. And the angiographic evidence of spasm is not subtle. You're going to see it. It's not going to be a question of whether or not it's there. If they don't have that angiographic evidence, then they probably do have microvascular spasm if they have the other 2. It's important to diagnose still because we can treat it, but their treatment regimen might vary a bit, so important to note. So as an example here, we see their baseline angiogram on the left-hand side. They essentially develop no, or go down to no LAD here when the intracoronary acetylcholine is given. And then again, it's quite reversible with the nitroglycerin. So it's a nice test and easy to do. Again, we do this before we do our microvascular testing because once we place that wire down the coronary artery, that might in itself invoke spasm. And so we'll give nitroglycerin prior to doing any sort of our flow measurements with the coronary wire down, and that will confound our results for the spasm testing. So spasm is done before microvascular testing in our lab. If we diagnose them with spasm, we don't just stop the testing there, take them off the table. We still do our microvascular testing, and that's important because about a third of patients will have concomitant microvascular angina on top of their spasm. It changed their treatment plan, and important to note for them. They're going home with half a diagnosis if we don't do the complete testing. In the lab here, we use a pressure wire X and Abbott system to measure coronary flow and microvascular resistance. It's nice because this is a conventional pressure wire with a couple extra sensors on it. And so we can do our epicardial invasive physiology with this and then just go on to microvascular testing. It kind of streamlines our flow of workflow in the cath lab. So like I said, this is a pressure wire, kind of like what we would use routinely for FFR, but it has 2 extra sensors on it that are temperature sensors, and that allows us to do our thermodilution to calculate the microvascular resistance. We kept this in mind, so when they designed the pressure wire X, they were doing bolus thermodilutions. So similar to a Swan-Ganz catheter where we're giving a bolus of saline, we're measuring the transit time from one point to another. We do this both at rest and then at stress after giving IV adenosine. The thought process being when the heart is stressed, there should be an increase in flow, and that transit time should be much faster. And so you can see here in a normal patient, in the yellow box there, their resting average transit time was 0.5. And at hyperemia or peak hyperemia, their resting transit time became markedly faster at 0.13. And this correlates on the right-hand side here with their coronary flow reserve being normal at 4 and their IMR being normal at less than 25. The one thing to note is that coronary flow reserve, as Dr. Abadi had mentioned in non-invasive testing, should be above 2. We found in the cath lab it really should be above 2.5. So it's a bit of a different value here. The other thing to note is because this testing is relatively new, I think in the past 5 years is really when we started to use the pressure wire X system. We don't really know what a quote unquote normal resting transit time is. It can be different for every single patient. So we're still gathering data and understanding kind of what is normal for every patient, but it's going to be completely different. And as an example here, this is a patient with structural microvascular disease. So you can see their resting transit times were in this 0.81 seconds range, and at hyperemia, they weren't really able to improve that much. At 0.66, this correlates with a CFR of 1.2 and the IMR in 43. When we have the discordance between the CFR and IMR, that's suggestive of what Dr. Abadi had alluded to with this functional CMD, where their coronary flow reserve is very low, but their IMR is normal. So their microvascular resistance isn't the issue. It's the structural, not a structural problem within the microvasculature. And I think of these patients as HFpEF patients. I think Dr. Ziada is going to go over a bit of the nuances of their treatment plans. It's still important to diagnose because we can target treatment. It's a bit different and a bit more difficult to treat, but it's important for them, I think, satisfying for them to get a diagnosis of that. So the biggest caveat of doing this bolus thermodilution is that it really is dependent on the operator. If I give a really big injection the first time and then a really slow injection the second time, that transit time is going to be completely different despite the fact that there's nothing wrong with their microvasculature. So more recently, we started using continuous thermodilution, which we're really excited about. So this is a pressure wire, the same pressure wire that we've already been using, but we use a specific microcatheter that allows us to deliver a steady state of saline into the artery to take away that operator error. And instead of calculating the IMR, we're calculating the MRR, and that should be above 2.7 in a normal patient. And so I'm not going to go into the nitty-gritty details here or anything, but I think the biggest thing to take home is that it's a bit more reproducible than the bolus thermodilution, again, because you're taking away operator error. And that's been correlated, again, with a better correlation between the results and the patient's Seattle Angina Questionnaire scores. And so we're hoping that that's going to be kind of our new standard of care in the next year or so here. So we've come a long way in terms of our invasive testing and what we can do. There's still a long way to go and a lot more information that we need to gather. Thank you.
Okay, you've seen this slide a few times now, the subtypes of INOCA or the endotypes, and it's important to distinguish between them because we base our treatments for microvascular angina or vasospastic angina obviously on the pathophysiology, which is somewhat different, and the therapeutics therefore will be different. We break down these categories a little bit further when we do invasive testing. Structural and functional CMD, as you heard, under the microvascular angina or the microvascular dysfunction category, macrovascular or epicardial spasm versus microvascular spasm under the vasomotor disorders or the vasospastic angina. Although I will say that microvascular angina will tend to, microvascular spasm will tend to behave a little bit more like microvascular angina, and at least I personally treat microvascular spasm as microvascular angina. This is a treatment algorithm that was proposed as a consensus statement by a group of the European Society. And basically, it looks at both non-pharmacologic and pharmacologic treatments. It's really important to emphasize to patients lifestyle issues, such as exercise and weight management and smoking cessation. We also have to control the risk factors, as Brian mentioned and Dr. Ellis mentioned. The risk factors for these patients are the typical risk factors of hypertension, dyslipidemia, diabetes, and obesity, and so forth. And so we have to work on that in addition to working specifically on CMD. The anti-anginal medical therapy in general, for microvascular angina, we use beta blockers primarily, and we can use calcium channel blockers or ranolazine. Some of the other medications that you see on the list are not necessarily available in the US. For vasospastic angina, we focus on calcium channel blockers and nitrates. Statins, aspirin, and ACE inhibitors or angiotensin receptor blockers can be considered for their role in possibly improving endothelial function over time. CORMICA is a really important trial in the space of microvascular dysfunction because it was the first randomized sham-controlled trial for the diagnosis and treatment of INOCA. So basically, the invasive testing, as Dr. Young mentioned, were performed in 150 patients. They were randomized to two groups. One group, the physicians were told what the results of the tests are. The other group, the physicians were not told what the results are, and the patients were in the first group treated according to the endotype that was unmasked by the study. And in the second group, the patients were treated empirically. And the primary endpoint was basically relief of angina and improvement in quality of life. And as you can see here on the graphic, the patients treated on the basis of the invasive testing or with the understanding of what the endotype is had better relief of angina and better quality of life. So suggesting that the treatment on the basis of the endotype is actually effective, and that the testing actually helps improve the quality of life of the patient. It's not just a theoretical endeavor. So when I see a patient with INOCA, we really have to set a few rules or set some basic understanding with the patient. The first thing is there's really no therapeutic approach or therapeutic agent that is approved for the treatment of INOCA. And so we use the tools that we have, but we have to understand that we're using them based on our understanding of how the drugs work, but not necessarily that they're specifically made for INOCA. So therefore, the treatment must be individualized. We focus on what the endotype is, and we focus on how the patient responds. So there's a bit of trial and error and a bit of a process. It's not a silver bullet, if you will. And I tell the patients that almost always we can improve their quality of life, we can improve their symptoms, and we can improve their functionality once we get to a stable regimen, once we get to what really works for them, they will feel better. I'll mention a couple of things about some of the things we use. It's really important to, Dr. Ellis had mentioned that there is really no good data on therapy, and that's absolutely correct. But there's some data to suggest to us that certain variables, certain agents or certain approaches have a valuable role. Exercise training is one of them. As you can see in this really small study, but old and reasonably well done, shows that exercise training improves patients' endurance, reduces their frequency of angina, and improves their functional capacity. And so most of our patients we send for cardiac rehab once we have some control over their symptoms, and most of them actually do benefit significantly from that. Beta blockers obviously are important for any type of ischemic heart disease. I want to mention nebivolol as one of the agents that I specifically use in this type of patient because of two main features of nebivolol. One is that it improves nitric oxide production, intrinsic nitric oxide production by the endothelium. And so it gives you a nitrate or a vasodilating effect without necessarily the side effects of nitrates that we all know about. The second thing is has an endothelial function effect as well. As you see on those graphics below, this is brachial artery reactivity, showing that with nebivolol, there's actually an improvement in brachial artery reactivity. And so I think this is one of the beta blockers that are significantly valuable or really valuable in this type of patient. Ranolazine, as you all know, is a drug that was invented and was made to treat ischemia or angina, I should say. Its role is well documented in patients with angina and obstructive CAD, but it was also tested in CMD, and you see here a meta-analysis of 6 small randomized trials, really small, 300 patients all in all, showing that there is an improvement in angina frequency and there is an improvement in quality of life. But as you see, the effect is not very dramatic. As you see, in treatment satisfaction is not very good. So we usually use this in combination with other things. I want to bring up the issue of HFpEF. I think this is really important. In not one study, but more than one study, this is an example of one study, that HFpEF is associated with microvascular dysfunction in a significant majority of patients. In fact, in this study, 75% of patients with HFpEF had evidence of microvascular dysfunction. And frequently, this is the functional variety. And I think this is important because when it comes to treatment, we have to think of microvascular dysfunction, treating the angina, but also treating HFpEF. And this is a recent publication that looked at the endotypes and the treatment by endotypes, listing all the drugs that can be used in different endotypes. Basically, I want to emphasize the point that therapy really should be based on endotypes. So let's go over this again. This is the basic breakdown of the endotypes. In patients with vasospastic angina, as I said, we mentioned the risk factors, the exercise training and the weight management, the statins and aspirin, ACE inhibitors are also a possibility. But the primary treatment here is calcium channel blockers. We use dihydropyridine or non-dihydropyridine. We use higher doses. Sometimes we use combinations. The second line of treatment is nitrates. I prefer to use less nitrates because of the side effects, but sometimes patients respond to nitrates better, and so we would have to do that. Potentially useful here is L-arginine as a precursor of nitrate production intrinsically, and there is some trials going on endothelin antagonists, although the results are not out. If we look at microvascular dysfunction or microvascular angina and microvascular spasm, we use the same sort of risk factor management algorithm, but the first line of treatment here, medical treatment here, is vasodilating beta blockers. As I said, nebivolol or also carvedilol can be useful here. The second line is usually ranolazine. And obviously, we have to treat the risk factors, and sometimes that includes antihypertensives as well. For HFpEF, I think it's really important, if we think that HFpEF is part of this, is to add dapagliflozin or an SGLT2 inhibitor, and possibly a mineralocorticoid antagonist as well. I think that when patients have a significant component of dyspnea in their symptoms, these agents become much more valuable. And we've seen a significant improvement in symptoms with dapagliflozin, spironolactone, and nebivolol combinations. There are ongoing trials, as Dr. Ellis mentioned, the Warrior trial, but there are a number of others that are looking at endothelin antagonists, for example. There are trials that are trying to expand the Cormica approach to become more international. And there's a registry that are trying to examine prevalence and prognosis of INOCA patients in the contemporary era. The only device that is considered for patients with INOCA is the coronary sinus reducer. It's a device that was made for non-revascularizable coronary artery disease and intractable angina. There is a registry that is trying to look to see if there is a role for coronary sinus reducer in patients with abnormal CFR. We are enrolling in COSIRA-2, which is the current investigational device exemption study, and are considering a number of our patients to participate in this trial as well.
We're going to talk about myocardial bridges, and as everyone knows here, it is essentially when your coronary artery is no longer only has an epicardial course, but also has a intramyocardial course in a segment of it. This can either be partial or total encasement with myocardial fibers. It can occur in any coronary artery. Most commonly, though, it's going to be in your left anterior descending. It is mostly a benign entity, with some exceptions. There have been some gene mutations associated with coronary myocardial bridges, but there's not one specific. Some of them are actually also associated with hypertrophic cardiomyopathy or your WPW and other things like sodium and potassium channels, but nothing quite specific. Now, the prevalence is overall unknown. It depends on what kind of modality you're using. Coronary angiography can be up to 6%, but also if you use IVUS with coronary angiography, you tend to pick it up a little bit more, up to 23%. Coronary CT up to 22%, but that depends on the criteria. So are you also using the more superficial bridges, which are 1 to 2 millimeters in depth or not? And then autopsy series, anywhere between 20% up to 80%. Now, coronary bridges are associated with sudden cardiac arrest, acute coronary syndrome, and angina in that subset. Not all of them, obviously, but in a subset. This here is an autopsy series of 53 cases of sudden cardiac death. 21 of these patients actually have what we call significant myocardial bridges, so 2 millimeters or more and 20 millimeters in length. And they all had increased myocardial fibrosis and edema, which can obviously lead to electrical instability, and then you can have this cardiac arrest. This was a study of 197 patients with CTs that had bridges, and in the subset that actually met the criteria of a significant myocardial bridge, they actually had an increase in adverse cardiovascular events, including acute coronary syndrome. So if you look at this graph, it shows your coronary flow, and the majority of your coronary flow is going to be during diastole. The dashed orange line is a normal coronary flow at rest, and the full orange line is your coronary flow with stress. The blue line is a significant myocardial bridge, so you can see how during diastole, where the majority of your blood flow is going to be, you have a significant impedance to flow. So the pathophysiology of myocardial bridges, not only is it the dynamic obstruction, but that subsequently leads to changes in your coronary perfusion pressure, endothelial dysfunction, myocardial fibrosis, vasospasm, which we've discussed already, accelerated atherosclerosis. And that also will depend on the length and the depth of the bridge and the extension of that compression into the diastolic phase. And importantly, other patient factors such as how old are you, your heart rate, blood pressure, and what has been mentioned, which is really important, is your diastolic function of the ventricle and if there is a concomitant LVH or not. So the current guidelines tell us, yes, if you have a bridge and you have ischemia, go ahead and intervene on it, which can obviously first line be medication, which is calcium channel blockers and beta blockers, or unroofing if you fail medical management. The problem is how do you test for ischemia in a myocardial bridge? It's still actually unclear. Your non-invasive stress tests are going to be picking up your fixed plaque, not necessarily a dynamic ischemic lesion like a myocardial bridge. So a negative stress test does not necessarily mean that you're not going to have future adverse cardiovascular events, and it can be falsely reassuring. And that's why we moved to the invasive functional assessment at the Cleveland Clinic, including the FFR and IFR that Dr. Young has already discussed briefly here. We mostly actually focus on IFR. Why? Again, because the majority of your blood flow is going to be during diastole, and that's what we want to focus on, but also for another reason. In bridges, you actually have something called systolic overshooting, which is if you have your pressure wire in the vessel and the bridge is actually now being compressed, you have this super high waveform that you're seeing in that top IFR slide here. You see the yellow how it shoots way up, and that in an FFR can actually average out your value to be completely normal, whereas your IFR is not hampered by the systolic overshooting. And this was actually here a study from 2018 that specifically looked at that, where you tested bridges with both IFR and FFR, and the FFR actually ended up being normal in the majority of cases where the IFR was abnormal. So IFR is the ideal study. In addition to that, we use a more strict criteria of ischemia, which is the less than 0.85, less than or equal 0.85, and that is really based on the initial studies where less than 0.86 value had actually the strongest correlation to your adverse cardiovascular events. In addition to just doing the rest, you have to mimic what happens to these patients because it's mostly an exertional problem. So you add the butamine, and that mimics your increase in heart rate and your contractility to bring out that ischemic event. Some of them will actually have ischemia at rest, but the majority actually need to elicit that with the butamine. I also use Ivacin in the majority of these patients, and the reason for that is sometimes you have plaque that can actually alter the IFR value, and you need to see that because it can change management. And plaque can actually be underestimated sometimes on coronary angiography as well. I'm going to go through some very quick cases. This here is a 16-year-old basketball player who actually had classic anginal symptoms whenever he would try and play. And then when they would test him with blood labs, when he'd go to the ER, he actually had positive enzymes. And then they did it again where they just put him on a stress test and then drew labs, and he had positive cardiac enzymes. And you see here in the coronary angiogram, this is a very long LAD bridge. Not always very deep, but definitely very long. And his stress IFR was 0.69. He underwent unroofing, and post-op his stress IFR normalized to 0.87. This is a 42-year-old woman who actually came to me because of the anomalous right coronary. However, on stress IFR testing of that, it was completely normal at 0.93. But there is an association with anomalous right coronary arteries and myocardial bridges, so you want to look at the left system if they're coming in with an anomalous right. And her stress IFR of that bridge was actually positive at 0.82. You actually also see that systolic overshooting in that top panel as well. So she ended up undergoing both a anomalous coronary unroofing and an LAD bridge unroofing, and her post unroofing stress IFR normalized at 0.92 of the LAD bridge. Lastly, I think it's extremely important when you're testing these patients in the lab to look at plaque and actually do a very thorough pullback. This is a patient that has, as you see in this angiogram, a osteo LAD lesion right at that bifurcation of the LAD and the diag. The pre-op rest IFR at a heart rate of 73 beats per minute only was 0.46, 0.44, so very positive. And as you do a pullback across the bridge, it was also quite significant, goes up from 0.42 to 0.71, but it's still ischemic. And then as you pull back further across that osteo lesion, then it normalizes. So both lesions actually are causing ischemia in this, and this patient ended up with surgery with both unroofing and edema to LAD. And the post-op, the rest was completely normal at 0.92, but I was also able to stress this patient all the way to a heart rate of 142 beats per minute with a normal IFR at 0.90. So at the Cleveland Clinic, we have a specific protocol. If you're symptomatic, you come in, you get the full testing, and that will include your invasive functional evaluation, non-invasive stress test. Specifically, we use the butamine PET. You can also do exercise PET. We also do an objective evaluation like a metabolic stress test, coronary CT. And as I said, we start with medical management. If they fail, then we go to surgical management. This is the 2021 initial data that we had, where we only had 6 myocardial bridge patients with improvement in their post-operative IFR values. We now have up to 130 patients with preoperative IFR. And as you can see here on the graph, your overall pre-op IFR is quite significant at 0.74, and your post-op stress IFR is essentially normalized to 0.87 because we're using the 0.85 as our ischemic guideline here. This is obviously an ongoing study. There's still a lot of things that we're looking at, which is what's the presentation, the comorbidities, the correlation with non-invasive stress testing, the IVAS assessment, the spasm studies, and obviously your cardiovascular outcomes. So overall, I would say myocardial bridges are common and mostly still are benign. But in a subset, these patients can actually have adverse cardiovascular events, including sudden cardiac arrest, ACS, and angina. In those that have these adverse cardiovascular events or limiting symptoms, you do want to do a full and thorough evaluation to see if that bridge is culprit. I don't want to say that if you have a negative stress test, you can ignore it. You want to do a thorough evaluation, including the IFR testing in some of these patients, if the clinical scenario merits it. So overall, the IFR is a promising tool. I think there's still a lot of unanswered questions. We still don't know, how do we actually have an ischemia threshold in your non-invasive stress test so that we don't have to do cath anymore? We want to know, what are the high-risk features? Do we need to repeat testing on these patients after 10 years, for example? Is the threshold that we're using right now for IFR the accurate test, the accurate threshold or not? You want to always look at concomitant vasospasm and plaque because it can affect your ischemic burden. And then I am not a proponent of PCI bridges. I think it can be fraught with complications, including stent fracture, perforation, and high rate of ISR, although there are some publications about that. I think surgical management is best, and Donna will discuss that. And our post-surgical results are actually quite excellent. I think we still need long-term outcomes. And as always, this is a multidisciplinary, multi-modality collaborative effort. Thank you.
All right, so just for the sake of time, I'm just going to skip over the first couple of slides since Dr. Gabriel already went over kind of the incidents and how these patients can present and how it's kind of worked up. But from our standpoint, just a quick mention, I totally agree with everything Joanna said about workup, that we want some sort of functional testing to show that this patient is experiencing ischemia from this bridge, because there are so many patients, like we pointed out, that have these bridges and they're completely asymptomatic. And so I'd like to talk over a case, courtesy of one of my colleagues, Dr. Roselli. I just think it's a fantastic case, recently done. So young gentleman, 56 years old, extremely active, but was getting progressively shortness of breath while playing hockey. Really no past medical history except a lumbar herniated disc. He had an exercise stress test, which was positive. He had chest pain and ST depression, went on to have an echo that was normal, had a SPECT that showed ischemia in the LAD territory, and then came for coronary angiography. So these are the pictures, again, courtesy of one of our colleagues here, just showing the left main, grossly normal, but really let's look at the LAD. As was pointed out, it's often the LAD that's affected by these bridges. And this is, I think, a beautiful shot showing that bridge right here in the middle. You can see it's really compressed. And it shows it quite nicely. It can be difficult to find angios that show these really nicely. And again, just another slightly different angle showing that mid-LAD, that long segment here that's being completely compressed. And functional testing was done. IFR was grossly positive with 0.71 distal to that bridge when the patient was stressed in the cath lab. And on pullback up here, it was normal. IFR was like 0.97. So this gentleman meets, you know, kind of all the things that we're looking for to say, yes, we can take him to the OR and confidently feel that we can make this gentleman's quality of life better. So this is, again, the video here. I'll pause at times. So this is how we started off. We find the LAD where it comes out epicardially and then work our way backwards. There's often all these crossing little veins that you have to clip and divide so you can get down to the muscle and get down to the LAD. So it's just a matter of being patient and persistent with cautery and blades, and using our little retractor here to help show, because again, this will show in a moment, but this bridge was quite deep. It was almost 1 centimeter deep. So you feel like you're digging forever. That's that muscle there, that brown tissue in the middle that we're slowly cutting through here, or my colleague's slowly cutting through. And that's all it is, because as you can imagine, you could easily enter into the RV. That can be one of the complications or pains with this. A lot of hemostasis as you're cutting through that muscle. We're giving cardioplegia here to help identify what could be bleeding. Again, finding crossing veins appropriately, controlling those, cutting through them. You see the LED there, that white purplish vessel right underneath the blade. Really important to get all the last fibers of those crossing muscle fibers over the LED anteriorly, so you really have no further constriction, completely free it up, not just anteriorly, but also laterally, which Erica's gonna show really nicely here. You wanna make sure it's freed up laterally as well, because that can also cause compression. And so careful, again, to identify any branches coming off on the side, that you leave those intact, but free it up on both sides and both anteriorly. And then coming up proximally, we're starting to get out of muscle, but we feel it's important to really free it up when you're coming out of the muscle, because we think where it enters, as you can imagine, you can have that kinking and that distortion proximally, but also distally where it comes out. So that's really important that we really identify all the way out to muscle proximally and all the way out distally. And you see with a ruler here, it's about a centimeter deep, which when you're in there, that's deep. And it was quite long, about 4 centimeters long, which he'll show in a minute here. We use clips just along the fat, the epicardial fat, which is really as a marker for post-op imaging to show where that bridge was and show that it's been released, to see, does it look freed up now? And so that's our end result there. Again, about 3-4 centimeters long, nicely hemostatic. And then post-operatively, the patient did quite well, went home on day 5, I think. This actually was just done about 3 weeks ago, so we don't have our post-op IFR testing done yet, but they did have a CT. And if you can see with the cursor, these white marks here, those are the clips. So that's demonstrating where this whole segment of LED was unroofed or debridged. And there's a couple different angles here just to show we really don't see any compression here. Again, these are still images, apologies, but no compression, no weird kinking of that LED. So really, really fantastic result, I'd say. Well, I say that with confidence because it's not my patient case. But I think what we're demonstrating here is unroofing. It's a very safe, reproducible procedure. And really, as it's been pointed out, this is something we're still learning about to see how do we really work these patients up, what testing, what values do we want. But so far, what we're using are flow calculations, which are really key in preoperative decision-making to know, is this lesion causing, or is this bridge causing issues, and how can it guide our management, and then also for follow-up to know, have we treated it appropriately? So thank you so much.
This is one of these questions I take care of in my family practice. You know, right? Patients are always asking me about who they should see, and they tell me they have, chest pain and they're worried about things. And so thanks for teaching me about INOCA. At least I think there's a lot for us to learn here. I find it interesting that some of the testing is done, with acetylcholine, and we're using these beta-1 agonists. Do we think there's a role for better understanding of the brain-heart connection? I'm dividing autonomic nerves every day in the operating room, sometimes just giant autonomic nerves that run along the aorta. Do we think there's a role there that we need to understand that better in this disease state?
I can add a little bit to that. So spasm patients, documented patients that have spasm, fail medical therapy, we occasionally will refer for sympathectomy. And the literature there is scant. The biggest data, or largest data, comes out of Asia. The success rates are somewhere in around 2 out of 3. I actually recently did this with one of my patients. These patients are often complex because they've been misdiagnosed, or they have other issues. So the particular patient I'm talking about really didn't get much better. But I do think there is a role there for spasm patients. And microvascular disease, I'm not quite so sure.
So there is definitely an association or an interplay with autonomic function and coronary flow regulation. So Robert Wilson and I from neurology, we have a lot of patients in common where they have dysautonomia and they have vasomotor disorders as well, such as microvascular spasm. And interestingly, we have started seeing a lot more of this in the patients who had other signs or other evidence of long COVID. So there may be a role, or there may be definite, or I should say there is an interplay between autonomic function or autonomic dysfunction and coronary flow abnormalities. Absolutely correct. We need to understand it better. We just have an association. We have some clues, but we really don't understand how it works. There is definitely a role for autonomic control of coronary tone, and that's the basis of the sympathectomy that was done for spasm patients. But it's probably more than just that.
Excellent presentations. So I have one question that I know that we divide the microvascular disease or not, but the the epicardial disease can be also associated with microvascular disease. So why we have to separate these two? Because most of the people who have epicardial disease probably have microvascular disease, and the reason why many people after stenting or bypass surgery have chest pain could be related to that. So what kind of data do you have to analyze the microvascular disease in patients undergoing stenting or whatever else we are doing?
Absolutely correct. So we actually have a project, an ongoing project, and I think we actually are ready to submit something in the next probably a couple of months. And proudly, I would say it's spearheaded by one of our case medical students. And we're looking at microvascular dysfunction in patients who had prior revascularization. So we have a lot of these patients who would come in, as you exactly said, Dr. Kapadia, patients who had a stent or a couple of stents, and then they come in and they say, I'm not feeling any better, or they felt better, but now they have symptoms, and we do an angiogram and their stents are widely open, widely patent. And so we do microvascular testing in those. We have identified a very significant proportion of patients with explanations for their symptoms in the form of either microvascular dysfunction or some kind of vasospastic disorder. The interesting thing we're trying to break down a little bit is whether the microvascular dysfunction is always structural, which is related to probably the same risk factors as you mentioned that cause their coronary disease, or if they have functional CMD and signs of HFpEF, which is sometimes interesting, especially in patients who never felt better. Sometimes people would have symptoms, they would have an angiogram, they would have coronary disease, they get revascularization, but it may be, at least in a few patients, true unrelated. So their symptoms were always HFpEF, but they did have a tight lesion and got that revascularized. In those patients, we reached that conclusion in retrospect. There may be a time when we do this testing more routinely before revascularization, but at this point, we are about to try to just simply submit a paper describing the types of microvascular dysfunction that we see in patients who had prior revascularization.
And just to add to that slightly, in Absorb 4, we studied patients very carefully with careful questionnaires after stenting, and a full 50% had angina within the first 6 months, in spite of no restenosis. Yeah.
Hey, great presentation, Joanna and Donna. So the comments about myocardial bridges, obviously on non-invasive CT scanning, we see an awful lot of these bridges. And so there's that group, there's group that has typical, atypical symptoms. Some of it could be supratentorial. Are we recommending that everybody get all testing?
Yeah, I think, Joanna, you can take that one.
No. So the people we're studying are the people that come to us symptomatic. So you have to have some symptom to actually warrant testing. As we said, bridges are quite common. It is most commonly benign. We're only evaluating those that have a symptom that needs further testing. So those that is incidental finding, we actually recommend just, reassurance for the patient.
I think actually you also mentioned that when they have symptoms and when we have ruled out other explanations for their symptoms, we still put them on medical therapy for a good amount of time before taking them for invasive testing. So first is they have to have significant symptoms. Second is rule out other explanations. Third is put them on medical therapy for bridge. And then fourth, if all fails, then we start digging a little deeper with invasive testing.
conversely, charming, but I think you have to be careful about tutorial diagnosis. Nobody wants this.
So related and conversely, in the patient that incidentally, they get a cardiac CT for something, you find a bridge, or they come for a cath for some reason, you find a bridge, they're asymptomatic. What are your recommendations or your thoughts on, aggressive physical activity, workouts, things like that?
So again, we don't have really good data to say that you have an incidental bridge, you're going to be at higher risk of cardiovascular events. We know that patients that are symptomatic with significant bridges do have an increased risk of cardiovascular events, right? So if you're coming in and it's a purely incidental finding, then we do nothing about it and we don't restrict them from exercise. It's actually not good to restrict these patients. But however, we explain that, hey, if you are becoming symptomatic, then you do reach out because, again, the hemodynamics can change. If these patients get older, if they develop plaque, if they develop spasm over time, right? It's not something fixed where if you see them at 30 and it's incidental, they're good for life. If they come back to you at age 55 and they have more plaque or a lesion proximal to the bridge, that then warrants further evaluation.
That's a common question from patients, actually. When you explain to them that they have a bridge, they always ask, since I had it, since birth, why do I have symptoms now? And you're right, because as we age, the arterial compliance changes, the atherosclerosis has an impact, the myocardial stiffness has an impact. So a number of things change as we age. And so we probably see a lot of those highly symptomatic patients in a sort of a certain age group, although it has been reported in young athletes as well. But in those cases, in young athletes, it's usually a very deep and very long bridge. Right?
Yeah, like the case I presented, it was super long LAD bridge in somebody who pushes themselves. But the average age actually of our bridge study is about in the mid-40s, I would say.
This case we presented actually had a cath 10 years earlier and was told, don't worry about the bridge. We didn't do all the invasive testing. But I think as he grew over 10, 12 years or something like that, there's also a little kink on either end of that bridge that may have become worse with time because the symptoms got worse.